Hi, everyone. We'll just give people a minute to come in and then we'll get this webinar started. Thanks for joining us. All right, I think we can get started. Welcome, everybody. My name is Laurel Damashek. I'm the Executive Director of the International Society of Glomerular Disease, and we are really pleased to be hosting this webinar on protecting against nephron loss, how targeting the kidney leads to better outcomes in IgA nephropathy. In a moment, Dr. Bruce Hendry is going to take over and introduce the panelists who will be talking today. Just a few housekeeping notes before we get started. If you have questions, we welcome those. Please put them in the Q&A. You'll see the Q&A button at the bottom of your screen. And we'll address all of those questions after Bruce's presentation in the panel discussion. And this also has closed captions available. So if captions are something that you would benefit from, feel free to click on that CC button. And if you have any questions, put them in the chat. We are so glad that you could all join us today. And without further ado, I will hand it over to Bruce Hendry.
Laurel, thank you very much indeed. And big thanks from myself personally and Travere to yourself and the ISGD team for inviting us to present this educational presentation. I'm going to start by saying that we will be focused on telling you about the Sparsentan clinical development program and recognizing this as an international society. Many individuals will be from domains where it's not a licensed drug. So important to say this is an educational symposium, and the purpose of this is to provide information to nephrologists and to other stakeholders, and that is the sole purpose of it. I'm going to start by beginning to introduce our panel. I am, as I said, Bruce Hendry. I'm a nephrologist working for Travere. I'm based in London, UK. I've got three really great panelists working here today who have great practical experience of the nephrology clinic and of the treatment of IgA nephropathy. I just want to get them to introduce themselves very briefly. Maybe I could start with Gaia.
Hello, everyone. I'm Gaia Coppock. I'm a nephrologist at the University of Pennsylvania. I specialize in glomerular disease here, and I run our glomerular disease clinical trials program.
Thanks, Suneel.
Hi, Suneel Udani. I'm a nephrologist in community practice with Nephrology Associates in Illinois and Indiana, or NANI. My focus is in glomerular disease, and I was a site PI for PROTECT as well as other IgA and glomerular disease studies.
Thank you. Last but not least, Chris.
Thanks, Bruce. Hello, I'm Chris Gisler. I'm a medical director with Travere and also a clinical nephrologist in the Pittsburgh, Pennsylvania area.
Thank you all. So this is the agenda. I'm going to begin by giving a fact-based presentation, but it's largely about the development program for Sparsentan. But rest assured that I will at the end draw back and put this in the context of the overall treatment landscape in IgA nephropathy, so that the discussion can really range more widely as needed. But I'm going to focus on the Sparsentan development program in the material that I present. And I'm going to talk both about the background to the agent, about the phase 3 PROTECT study, and the ongoing SPARTAN study in incident IgA nephropathy as well. So one of the first things I want to state and convince you is that patients with IgA nephropathy require an optimized treatment that targets the kidney in order to mitigate ongoing damage. If we think of IgA nephropathy, the mean age at diagnosis is typically quoted as 40 years or about there. And it's recently become increasingly clear that all people with IgA nephropathy are at least at risk of developing kidney failure, by which I mean moving to require dialysis within a 10-year period. And if you look at patients at diagnosis, many of them have significant kidney damage, that is stage 3 or worse, CKD, at the point of diagnosis by biopsy. The pathogenesis of IgA nephropathy has been summarized and indicated here by the 4-hit hypothesis. I'll briefly say that the initiation of this process is abnormality of the mucosal immune system in various locations, including the respiratory and GI tracts, production of underglycosylated IgA1, generation of an immune response to that, largely IgG autoantibodies, and then at HIT4, the deposition of these immune complexes in the glomerular and mesangial space. And at HIT4, a nephropathy begins, and a generation of damage of a vicious circle occurs in the kidney, leading to glomerular dysfunction, failure of the filtration barrier, filtration failure, and progressive CKD. And the events I finish that sentence with are occurring in the kidney and are ongoing in the patients we diagnose with IgA nephropathy. An evolving paradigm has emerged in which we can think of the journey of IgA nephropathy and its natural history as moving from a period when there is a disease-specific immune-mediated nephron loss to a phase when the dominant features are of a CKD damaging process inside the kidney. This is clearly oversimplified, but it does give us, I think, a good paradigm for thinking of how we best approach treatment. And if we think that the diagnostic situation is already one of significant kidney damage, it's clear that the treatment strategy requires a treatment that is targeted at kidney damage, as well, in many cases, as a treatment which might be targeted at the immune system and the autoantibodies and IgA production. So that's the context for the program of Travere studying the targeting of endothelin and angiotensin in the treatment of IgA nephropathy. The reason this program makes sense is that at HIT4, a range of cytokine driving factors initiate and progress kidney damage. And the agents endothelin-1 and angiotensin-2 are really important parts of that process, dominant parts of the process. They are both damaging, but they also work together and reinforce each other. So there is a tremendous logic at the basic science level in targeting both endothelin-1 and angiotensin-2 at the same time. And that is exactly what Sparsentan does. It's a drug which is a dual endothelin angiotensin receptor antagonist, or DARA. And if you wanted to target HIT4, you would design something like Sparsentan. You see on the right that at the cellular molecular level, the drug is anti-inflammatory, anti-proliferative, anti-fibrotic, anti-proteinuric, and it also is a glomerular vasodilator. All properties which on the theoretical basis that we see here should be nephroprotective in the context of IgA nephropathy. So a great mode of action narrative, but that doesn't prove that it's going to work in the real clinical setting. So I move to describe the PROTECT clinical trial, which is the hypothesis testing in a clinical setting that Sparsentan is an ideal hit for therapeutic. The trial I'll describe very briefly, randomized multi-center double-blind study. Importantly, there's an active control arm in which irbesartan is titrated to a maximum tolerated dose. This is a pretty much unique feature of this study, providing a high bar for Sparsentan to be tested against. Entry criteria, fairly well recognized for IgA studies now: biopsy-proven primary IgA nephropathy, protein excretion over a gram per day, eGFR above 30, and the patients are randomized to receive either Sparsentan or irbesartan, titrated up to their target dose and in a 1-to-1 ratio. Importantly, the irbesartan active control arm were able to titrate up to maximum labeled dose over the first 36 weeks in 96% of cases. Primary endpoint was the change in UPCR from baseline to week 36, and the key secondary endpoints were the GFR slope analyses, both total and chronic, up to week 110. These are the inclusion and exclusion criteria summarized. I won't read all these out, but just to note that secondary IgA and IgA vasculitis were excluded, as were patients with a biopsy showing crescentic IgA within 6 months of screening. So this was a focus on the primary IgA population. Immunosuppression significantly used within 3 months of screening was also an exclusion. So here is the primary endpoint result from the PROTECT study. The Sparsentan arm, shown in green, showed a dramatic and rapid reduction in proteinuria of the order of 50%, far greater than the signal in the active control arm, and the primary endpoint was met at 36 weeks. It's clear from this data that the effect on proteinuria was not just rapid and strong, but it's sustained over the full 110 weeks. And indeed, the active control adjusted treatment effect is in fact increasing during year 2. And you can see the results at the end of the study, double-blind period at week 110. Importantly, that potent reduction in proteinuria enabled a number of patients, almost 1/3 of them on Sparsentan, to achieve a complete remission of proteinuria, less than 0.3 gram per day, compared to about 10% in the irbesartan arm. So 2.5-fold increased likelihood of achieving complete remission in the Sparsentan arm. So the study, I think, has met its first test, that is to demonstrate powerful antiproteinuric efficacy. Here is the GFR data by visit over the 110-week double-blind period. You'll see straight away that the Sparsentan arm in the green at all time points from baseline shows a higher, that is better, eGFR level, and the differences are indicated at the time point shown by the digits on the figure. If you look at the top, you will see that at 1 year, the Sparsentan arm change from baseline is 1.9 mil per minute per 1.73 meters squared, better than active control. And that benefit accrues over the study, and at the end of 110 weeks, the difference is 3.8. So in terms of change from baseline, the study is clearly demonstrating a renoprotective effect of Sparsentan. Now, the eagle-eyed might notice that these numbers are slightly different from those published in the Lancet paper, Rovin et al., on the PROTECT 2-year data. This difference arises because the FDA made the decision to analyze and present the PROTECT data as an intention to treat analysis. And these data on this slide are from that analysis and from the US label. These differ slightly from the Rovin et al. Paper, but the differences are small. The direction of the difference is that the data I show now strengthened the statistical and clinical evidence of nephroprotection. So if you look at the bottom of this screen, you will see the total slope and chronic slope, the difference between treatment arms of 1.2 and 1.3. In the Rovin analysis, which was an on-treatment analysis, those numbers were 1.0 and 1.1. So they've increased slightly. And importantly now, the p-values are both below 0.02. So what we have now is a robust statistical basis for a clinically relevant nephroprotection by Sparsentan against a high challenge of a maximum tolerated dose of irbesartan. The benefit on GFR delta to week 110 appears to be robust across the different baseline proteinuria levels. And the best way to look at this slide to judge that is the right-hand column showing the percentage reduction in rate of loss. And you see that all of the proteinuria levels, that is more than 30% improved compared to the irbesartan arm. This figure illustrates the real benefit to patients of having a reduced rate of loss of kidney function. And here the results of the PROTECT study are projected as linear eGFR decline to the point when a patient might be expected to require dialysis, that is eGFR around or below 10. And you see the increase in renal survival generated by treatment with Sparsentan. Fortunately, in IgA nephropathy, there is a robust evidence base for the assumptions here that eGFR decline is linear, that the linearity runs true over follow-up of over 10 years, and that the rate of loss of function at the early phase of disease predicts the reaching of eGFR values around CKD 5. And that data has been generated from the RaDaR UK registry demonstrating those linearity features. We can add something else to this figure, which is an assessment of the rate of loss of kidney function in standard of care. That is not when you specifically up-titrate, as we have here, the ARB, but the standard of care which we currently see worldwide. And this purple line is a mean assessment of the placebo arm of 5 IgA studies using very similar entry criteria. And you can see that in this setting, that is real-world care translated to a placebo arm of a study, the rate of loss of function is higher at 5.3, and the predicted time to kidney failure is brought earlier. Remarkably, it turns out that the RaDaR data analyzed as a standard of care analysis produces almost exactly the same result, such it's 5.4, as this analysis of clinical trials. So I think we have a pretty triangulated justification for the analysis presented here, and in the very optimistic sense that we have a chance with Sparsentan to increase kidney survival and delay the need for dialysis. Additional features of the PROTECT study were the assessment of the need for rescue immunosuppression, which was at investigator discretion. This demonstrates in the Kaplan-Meier here that this occurred much more frequently in patients in the irbesartan arm than the Sparsentan arm, and the odds ratio for needing immunosuppression was approximately 3 and favors Sparsentan, where few cases did require it. In similar format, this is the Kaplan-Meier for composite renal endpoints using either 40 or 50% reduction in GFR. And you can see that the figure, which is a 40% reduction, ESKD or death, indicated that these events occurred more frequently in the irbesartan arm than the sparsentan arm. And you can see the hazard ratios indicated in the center of this figure as bold numbers. The study was not powered for this endpoint, and these differences are not statistically significant, but they do represent a very encouraging trend. The safety profile of sparsentan was as well established in a whole range of clinical studies. The treatment cessations were more common in the irbesartan arm. Sparsentan was well tolerated, and this is the TEA table from the US label. Just point out one thing of note, which is that transaminase elevations were very similar across the two groups, in fact, slightly more common in the irbesartan arm, and there were no liver failure or DILI events in the study. So I'm going to switch gears now, having presented the PROTECT study, and I think what I've shown you demonstrates both a drug that can be used long-term. It demonstrates a strong antiproteinuric effect and also clear nephroprotection. But the PROTECT study was a study that was undertaken in a prevalent IgA population. And I'm switching now to show you some data from the SPARTAN study, which is a study from the University of Leicester, led by John Barrett and Chi-Kei Chung, in which sparsentan is used in incident IgA patients from the time of biopsy onwards. It's a single-arm, open-label study. Patients enter the study by having a biopsy demonstrating IgA nephropathy. They are chosen as patients who have not been treated with a RASI, and sparsentan is then given as a monotherapy first-line treatment for IgA nephropathy. Importantly, apart from the usual clinical endpoints, a series of biomarker studies are also ongoing, and I'll say a little bit about that as I go through a presentation quite quickly and briefly of the interim data from SPARTAN. So these are the results for the proteinuria expressed as the geometric mean change from baseline. And you can see that there is a very dramatic early fall in proteinuria of the order of 60 to 70%. And over time, that effect actually becomes even stronger, so that out at 36 to 48 weeks, there are reductions of proteinuria of some 80%. Numbers are small in this study. It's really a pilot, but these are really very encouraging data about an evidence of the success of sparsentan as a first-line therapy given at incident diagnosis of IgA nephropathy. These are patient-level spaghetti plot of the proteinuria data. You can see there was a whole range of baseline proteinuриas, and you can see the outcomes for the patients as you look to the right. Importantly, looking at complete remission, which is entering the shaded part at the bottom, 67% of patients were able to achieve a complete remission event. And this has very positive prognostic implications for future kidney survival. The GFR data, of course, there are large error bars in such a small number, but the GFR was stable over the 48 weeks reported here at interim. And you can see the numbers on the figure are the change from baseline. So at the end of this period, at least, we're talking about numbers around 0.7 minus 1.3, very little different from baseline. In the SPARTAN study, the blood pressure control was good, and it fell on initiation of sparsentan into a KDIGO compliant range, systolic less than 120, and was stable thereafter, as you see in this figure. These data in this slide address the question of fluid status in patients on Sparsentan. And you can see first that the weights don't demonstrate any tendency for gain as you look at the weeks. But importantly, the study also included a bioimpedance measurement of total body water. And the lowest row in this figure shows the total body water change from baseline at those 3 time points. And you can see that these are negative numbers, that there are reductions in total body water. So it looks as if there is no signal for any fluid overload in these patients receiving the DIARA Sparsentan. And that's somewhat unlike the picture that we've seen with single target ERA, which do seem to have a different profile from DIARA. So that kind of finishes the data presentation. And so I just want to spend a few moments before opening it up to Chris to lead a discussion to see where I think this leaves us in terms of the current and future IgA nephropathy treatment landscape. If we go back to the 4-hit hypothesis and the important role of hit 4 in the generation of kidney damage illustrated here, you can see a very exciting portfolio of new drugs are being developed to address IgA nephropathy. The ones that are in green here are US licensed. They include Sparsentan, targeted release budesonide or Nefecon, and the complement factor B inhibitor iptacopan. And I think this is a great position to have new drugs being brought. But in the next 2 to 3 years, with I think likely success of other programs, there's going to be a great deal of development and further choice in how we treat IgA nephropathy. Our view of Sparsentan is that it creates a superior foundational platform for the treatment of IgA in a whole cross-section of patients. And it is nephroprotective as a foundational treatment. And that treatment can then be the foundation on which we see the future for IgA nephropathy, where other drugs are added, perhaps in an individualized way as needed. Because I think it's important to remember that the objective here over time is to get all patients to complete proteinuria remission and to get the GFR slope to less than 1 in all patients. And to do that is going to require more than one drug in many cases. But Sparsentan is well positioned to be a foundational treatment for nephroprotection and begins the process that we might build to achieve the really big objective. So we drew this diagram, I think with the help of Brad Rovin, sometime before the KDIGO guideline draft was released a few days back. So I just put it up to indicate that it's not too far away from where KDIGO is moving, certainly in terms of the combinations of a foundational therapy and the choices you see on the left there. And I've been speaking about Sparsentan DIARA in that category, and the likely need in many patients to combine this with immune targeted therapy as well. So I won't discuss that in more detail, leave that to the panel, because I just want to get people to have a chance to talk through the Sparsentan data before we get into the bigger picture. So to summarize and finish, from my perspective, I hope I've justified to you the statement that you require an optimized targeted therapy that acts on the kidney to reduce damage. I hope I've given you the facts about Sparsentan, that it is a dual endothelin angiotensin receptor antagonist, and it acts directly in the kidney at hit 4. And I've then described the PROTECT data and some further data from Spartan showing the proteinuria reduction and, importantly, the preservation of kidney function over 2 years that Sparsentan appears to generate. And the context we have now as I mentioned, is that there are currently approved therapies for IgA nephropathy, which includes Sparsentan in the United States, but also Tacopan and targeted release formulation budesonide, which is Nefecon. So I think the future is both complicated and bright, and I'm very interested to hear more from our panelists about their own personal experience of treating IgA nephropathy. I'm going to hand over to Chris.
Thanks so much, Bruce. So I think with that, that excellent lecture there, I want to kind of turn to the panelists now and start just by talking about IgA nephropathy broadly first. And so I guess for Dr. Coppock, with all the new data that's come out, how has your approach to IgA changed, say, since you finished fellowship until now?
Yeah, I think the approach has changed a lot. And I think our patients feel it too. It's sort of it's a double-edged sword, but certainly much more positive than negative. But when I finished fellowship, and even until very recently, we sort of had, two options: RAS blockade and prednisone, and then of course clinical trials. And so the conversation about IgA nephropathy was much simpler and less hopeful. Whereas now, I think the conversation about IgA nephropathy becomes much more optimistic, but can be a little bit more confusing for patients and for physicians. And so it also makes our targeted endpoints more possible. And so in the past, even I think with kind of the more recent data from the RADAR study, there were always people, I think, who really would strive to target the lowest proteinuria endpoint that they could in patients with IgA nephropathy, although now I think the data are even more supportive of that goal. Targeting less than 0.3 or less than 0.4, depending, on how you want to take it, but versus like 0.5 or 1, which we used to, so not only do the data support targeting lower endpoints now, but we also are more able to do that with the newer drugs. And then I think to Bruce's point about multi-targeted therapy, I think that's sort of the next phase of IgA nephropathy, which is how people who I think specialize in glomerular disease are doing more and more of that, but it's still perhaps more broadly in people who don't see as much of IgA nephropathy, it can be a little bit confusing. What do you do first? What do you do second? When do you escalate therapy? And so it's a really exciting time. It's a rapidly evolving time. I think that in my practice, I would say now every patient I treat with IgA nephropathy, really it's a conversation about multiple options, and it's much less common to have kind of everybody on the same therapy. There's a lot more variety in my practice than there used to be.
That's great. And so Dr. Udani, kind of piggybacking off some of the things that Dr. Coppock said, where are you targeting now for your IgA nephropathy patients? So what is your treatment goal, and what's your approach if those patients are not at goal?
Yeah, no, as Dr. Coppock mentioned, our understanding of this is certainly evolving, and the target of getting UPCR less than 1 gram alone or only has been shown to be not enough. I think that's a radar told us, and so certainly we would like to get people as low as possible. Certainly under a UPCR of 0.5 gram per gram is, as KDIGO, up to the KDIGO guidelines suggest, and even lower if possible. I think we're also able to step back a little bit more now. Radar provided quite a bit of insight in not only looking at what target, but also thinking about the sort of the life cycle of a patient with IgA nephropathy. We're really talking about someone who should diagnose in their third or fourth decade of life, or maybe even younger. And so we really have to think about them for the long term. And any therapy we institute, we have to think, okay, what's going to be sustainable, and what is going to be intermittent or cyclical. How are we going to handle potential flares? So all that has to kind of go into our kind of our thinking in terms of approach. So I think that at first we, while there are very good immunomodulatory therapies or sort of disease-modifying therapies that are coming along, we also know that all of these come at a cost, right? Not only financial costs, but immunosuppression, need for vaccination, put you susceptible to certain types of infections out of the side effect profile that we know now, as well as may emerge over time as we have more people on certain therapies. So we still think that, okay, sort of non-specific nephroprotective therapy is the starting point. And we know that, as you've already outlined quite well, this idea of dual endothelin and angiotensin receptor blockade is very appealing as in that regard, as well as SGLT2 inhibition. And with that, in people with at least initial features that we can accept of, where we can give it a time period of waiting, meaning that they have not shown sort of rapid progression of declining kidney function already, that remains the best approach. I think that certainly it would be, in many cases, it'd be nice to be able to reach for, Sparsentan up front, immediately upon diagnosis. But practically speaking, we're not really able to do that just because of, drug approval, et cetera. So almost always it's still starting RAS inhibition plus minus SGLT2 blockade in very short order, and in a rapid reassessment, and within 4 to 6 weeks to kind of see tolerance, things like that, and effect. And then certainly are not waiting any longer than 3 months to then escalate further. If you've already started with dual blockade, then thinking, okay, what is the residual risk and what is the trajectory of UPCR going? As your proteinuria is still coming down, then wait for it to nadir. But if proteinuria is sort of plateaued again, where are people at? Are they remaining above that threshold? And then walking through what therapeutic options are, and also walking through whether participation in a clinical trial is still something that to be considered. Because while we have great therapies coming along, we have to also recognize that each of these trials, while big for IgA studies, is still a small population, and not every drug is going to work for every person. And so the more options we have, the better I think it'll be for everyone. So I do think that, in particular, the previous KDIGO guidelines very much highlighted the importance of clinical trial, consideration. And I think that we have to still keep that in mind. Not necessarily for everyone, of course, but if there are people that we think will not tolerate current therapies or they're not accessible, then still looking for those options.
And so, Dr. Udani, so you brought up a great point there about rapid kind of reassessment and not just placing someone on a medication and then waiting quite some time to follow them. I guess for Dr. Coppock, is that similar to your practice? I guess how quickly are you reassessing these patients? And then if they're not at goal, are you adding medications? Are you changing medications? What's your approach to that patient that may not be at that proteinuria goal that you desire? And how quickly are you reassessing them for that?
I also think, like a close time interval for reassessment is important. Like Dr. Udani said, a lot of these patients, certainly the ones that don't present already with a lot of fibrosis, they can be younger. We hope they have many years to live with their kidneys. And we know also that IgA nephropathy is a modifiable disease. I always tell patients, like, it's not how you come in, it's how you end up. It's an outcome that can be modified, which is a huge gift in kidney disease. Like, we don't have that with a lot of our diseases, and it's very encouraging. Oh, sorry, my lights just turn off when I don't move. It's very encouraging that we have. I mean, this is there. Like I'm saying, there's a lot of optimism, and so I think patients are also very eager to meet those endpoints, and there has been historically a bit of a complacency in IgA nephropathy because we see it as like a more benign GN. And I feel that that's really what the RaDaR data has taught us, and at least has brought to sort of light this sense that it may not be an RPGN in most cases, but that doesn't mean that it's not placing your patients at high risk of kidney failure in their lifetime. And that's something that can be avoided. So it's, when we teach our fellows about treating a rapidly progressive glomerular disease, when we talk about giving steroids, I would always say time is kidney. And so similarly, although the total time course is a little bit different, the sooner you can modify this disease, the better it is for your patients. And so I think, whether it should ultimately be used as first-line therapy, I think is a very important question to ask. I do like to add rather than change, unless obviously they're on an ARB and I'm switching them to Sparsentan. I have a very kind of aggressive approach to try to lower proteinuria as soon as possible and have that be a sustained outcome measure for my patients. So that's how I would typically approach it too.
And so for both of you then, so would it be correct to say that you're focusing on a foundational kidney protective therapy first, and then if they need it, you're also then, looking to that other side and adding an immunosuppressive therapy, but you're getting kind of them on board, very quickly to kind of aggressively treat these patients?
Yeah, no, I think that again, the long view has to be considered. And while, it is likely that, while we don't have data on this, it is likely that none of the immunosuppressive therapies that'll come about will be safe to use indefinitely, or will need an interruption of therapy, I think, at some point, depending on what else happens in a patient's life. And so, what can you do, quote unquote, foundationally? And I think that that's where endothelin receptor antagonists, RAS inhibition, SGLT2 blockade remain, and perhaps even others remain the key things to look for. And I think that it's important to recognize that it's not as if endothelin receptor antagonists, is a new concept in nephrology, and that it was, new for IgA nephropathy. This is what we've known, that endothelin is a key mediator of renal dysfunction, increased proteinuria, mesangial proliferation, interstitial fibrosis, all those things that we know we see in diabetic kidney disease, IgA nephropathy, other, non-specific proteinuric kidney diseases. And so this idea that, sort of using Sparsentan is sort of, novel. Yes, it's novel, but the concept of targeting endothelin is not. And it's just that we finally were able to identify a patient population where we could use it safely, effectively. And so I think that the leap to go there should be very low. I mean, to go to endothelin receptor antagonist, like I said, it's usually, there's some delay just because of, we don't have we can't go pick up Sparsentan at the local pharmacy. So you're going to have some delay, and the rare people that, their proteinuria essentially goes away with 6 weeks of RAS inhibition, again, very rare, we're going to need to escalate. And I think that, 6 weeks, 12 weeks at most, that's enough for me to see, okay, we need to step up therapy. And I think it's also important, just obviously these are conversations to have. Patients, need time to process some of these things in terms of, especially new therapies. I think that, drugs have been around for many years. They've maybe had friends or family on, and they can accept that more easily. But new drugs, there's a natural anxiety, natural apprehension too. And so I think introducing kind of the whole therapy landscape is important on the first and then subsequent visits, and recognizing that, we'll reinforce those conversations with each visit and see where patients are at in terms of, what they're ready for, but continually trying to highlight the importance of, okay, these are our goals. You're a young person. We want to keep your kidney function preserved for, the next decades. So I don't mean to sort of be, vague about the question, but because it is so nuanced, and you guys are all clinicians, those conversations, what happens in that room, it can be very different from one patient to the next, and seeing where they are is so key about, making sure they buy into the therapeutic goals as well as whatever therapy we're going to initiate.
No, absolutely, that makes sense. And when you're assessing your goals, so you're trying to get these patients to goal, and like you said, our primary goal is preserving kidney function. What biomarkers are you all relying on, predominantly when you're making decisions and treatment changes?
I'm a big proteinuria follower in IgA nephropathy. Of course, we look at GFR slope, but as we all know, as nephrologists, I mean, it's good that it's a slow change. In most cases, you don't want it to be a fast change, but proteinuria for me is like the primary target that I follow with these patients.
Yeah, I think that there's two interesting things that are going to come about. Well, one is, in radar, what is that lowest group of proteinuria that still has a ESRD risk? What is happening in those folks? And I don't think we fully understand it. What is the relative importance of hematuria? I think that's a increasingly sort of biomarker to be considered. And I'm also relying on that as another feature showing, if they're at goal proteinuria or near goal, but they still have persistent hematuria, I'm still worried. And I don't know if I really have enough cause to be worried. I mean, there is certainly evidence to support that, but it makes me then, at least now that we have better therapeutic options, it makes me more likely to reach for one of those anti-inflammatory therapies, i.e., targeted budesonide, iptacopan, because I still have some concern that they have ongoing injury. I think that how this all plays out again is too early to tell. But and what other biomarkers may be helpful. That's the other thing that we still need to know. But I think, as Dr. Coppock mentioned, I mean, proteinuria is a kind of easy one for us to look at and say, okay, that by itself at least should be the initial goal.
Right. So I want to spend a few minutes kind of turning our attention to Sparsentan and PROTECT, because there were quite a few questions in the chat, about that. So obviously, Bruce presented the PROTECT study, which compares Sparsentan to a maximum label dose of irbesartan, and showed those data. Do those resonate? Is that consistent with your experience with Sparsentan? Have you seen similar results in proteinuria and similar GFR data?
Yeah, that's been my experience.
Yeah, no, certainly it's been my experience, but I also will say we do a pretty, at least I think I have done an inadequate job of maximizing RAS inhibition, because we, seeing people, what they can actually tolerate versus what we think they can tolerate is important. So I think that was one of the, I think, most, very good scientific fidelity for the study design to do that, to make sure that therapy was maxed out. And, really then also highlights its benefit, because it is more than we've ever done before. So when we consider the data, it is sort of key to look at that. But I've been surprised at the immediacy of the response, as well as the degree of response, but also recognizing it's been variable. So yes, definitely have had positive responses, but it has still been variable in folks.
Sure. And then, so like you pointed out there, yeah, so seeing, it's not necessarily what we all achieve in clinical practice, right, is getting those patients to that max label dose of an ACE or an ARB. And so certainly, a highlight, of the trial there. Bruce, for you, there were some questions in the chat just asking specifically about the molecular structure of Sparsentan. And so the question was, is this one molecule, or is this a combination pill that's targeting both angiotensin and endothelin? So if you could kind of speak back to that again to kind of clarify any questions, I think that'd be great.
Yeah, that's a very straightforward one. So yes, it's a single molecule, and it was designed to have features at two interfaces that gave it the properties of a dual antagonist. So at one interface, it has a high affinity, highly selective binding for the ETA receptor, and at another interface, it has high affinity, highly selective binding to the AT1 receptor. A single molecule of sparsentan at any one moment in time is bound to one of the receptors. It doesn't straddle the two, but the micromolar, nanomolar concentrations of the drug are capable of interacting with both receptor groups and providing a selective inhibition of both pathways. So it's a single molecule, dual receptor antagonist, and was designed exactly as such.
And so there was also a safety question, Bruce, that I'm going to keep with you there. And the question was, so when hypotension was seen, in the patients on sparsentan? Were they permitted to be down titrated to have their sparsentan lowered from 400 to 200? Or what was done in those cases? How did the investigator manage the hypotension that was seen?
Yeah, that's a very good question. The sparsentan can be down titrated from 400 to 200, and certainly that was on occasions done. But an alternative or additional thought is that you can also consider reducing other antihypertensives. So my advice would be that if you have someone on a calcium channel antagonist who is hypotensive on sparsentan, I would stop that drug rather than down titrate, but both may be necessary. It turned out that very few patients had to stop sparsentan because of hypotension, so it did appear to be a very manageable side effect profile. And of course, nephrologists are very familiar with drugs that change blood pressure. I mean, we are used to dealing with the blood pressure as something we have to manage with treatment decisions. So I think it's a manageable property, and that in clinic practice, there are various strategies to deal with hypotension if and when it might occur. I'd also say that the overall fact looks to be that sparsentan at 400 is a slightly better antihypertensive than irbesartan 300. It's not a big difference, but it's a slightly more effective antihypertensive. And in a big picture, that's a good thing, because if you look at the totality of our clinics, we are not achieving blood pressure targets. So something that moves us in that direction is good rather than bad. And the result of that is that we have to manage slightly more cases of hypotension, I think. But on the other side, I think we have fewer cases of uncontrolled hypertension. So that's my personal thought about it, but I'm very interested to hear our other panelists.
And I wanted to turn it, over to Dr. Udani and Dr. Coppock to see, have you had issues with blood pressure control when you're using sparsentan, or what's your experience been as far as blood pressure management and sparsentan?
Yeah, mine's been variable. I'd say that some people have a very profound drop in blood pressure with it, and so I have had to dose reduce in some, but overall, I've tried to use the approach that Dr. Hendry just outlined in terms of, because many of them have been on multiple antihypertensives to begin with, and so this gives us an opportunity to get rid of some of the others.
Yeah, I second that. I mean, I think in our young people with IgA nephropathy, those are the ones that are probably at the highest risk of hypotension that don't require anything to start. And so, but as we know from trying to maximize RAS blockade in those people, you'd be surprised what people can handle. So it's really variable. I wouldn't say you can really anticipate. And just to circle back to Dr. Udani's point about the maximizing RAS blockade, I think we all learned that lesson from the PROTECT data, that we are usually more cautious than we may need to be. And so you absolutely can dose reduce, but rather than, stopping before, it's like, like with dialysis, when you're challenging a dry weight, you go until they feel it and then you go back up a little bit. It's like that that's what we should be doing with our proteinuria, with our anti-proteinuric targeting therapies, because it's equally as important.
Absolutely. Bruce, there was another question about the study, and that had to do with the inclusion-exclusion criteria. So we mentioned that having more than a gram of proteinuria was needed to be included in the study, but then when we showed the subgroup analysis, we showed those patients with less than a gram. So could you kind of comment on how some of those patients got to be less than a gram that were in the study, and then we were able to subgroup analyze them?
Yeah, certainly. The reason that occurs is because the units are different. The entry to the study was a protein excretion of less than 1 gram per day, whereas the analyses performed at 36 weeks and baseline that are used for that primary endpoint are proteinuria as a gram per gram of creatinine. And of course, those two numbers are not the same. Indeed, if you look at the baseline data, you can see it very clearly. And this is not just the PROTECT study, it's the other IgA studies as well, that in IgA, the gram per day number is about 70% of the gram per gram number. So you will be looking at a difference across the piece. So baseline characteristics of 1.75 gram per day would be linked to about 1.2 gram per gram. So the two numbers are not the same.
And, we did show, some benefit in those groups with less proteinuria. So I guess for Dr. Udani and Dr. Coppock, I'd ask, have you been using sparsentan kind of in that range where, you're certainly not waiting until they're floridly nephrotic, but have you used it when they're closer to that gram or maybe even slightly less than a gram? And have you seen positive results?
I have been trying to, I've used it like once or twice, until just recently, like last week, right? We would have to battle insurance to get it at those lower proteinuria starting points. And so it's been like a little bit of a process. So yes, I have just started to do that. And I think now the barrier to do it will go down. Since the radar data were published, I've been trying to not accept proteinuria of like 0.8, 0.7 grams in my patients with IgA nephropathy, especially knowing that there are alternative therapies when they're on kind of what we would call standard of care to try to. So I've been trying to put those people on Sparsentan.
Agreed. Same. Yeah, I think that what's interesting and about like updated guidelines and part of it was a complacency, I think, as Dr. Coppock mentioned, but also a therapeutic nihilism that we had to accept because after stop IgAN and testing, the original testing, we saw that okay, we have therapies that can lower proteinuria, but the cost is significant and the trade-off is not worth it. And now, I guess we sort of accepted a gram because like, well, that's the best we can do with the therapies we have. So we might as well like, we'll accept it doesn't look too bad based on, the Toronto data, et cetera. But now we're like, okay, we have more data to suggest the lower proteinuria goal is what we need to do. And we have tools to get there and tools to get there safely. So, we're not going to accept 1 gram. We're going to get lower. I think what's going to be the challenge is also in clinical trial design, because those are still at higher degree of proteinuria. So when we think about, again, new therapies, additional therapies, a lot of them are still at higher degrees of proteinuria. And, if our goal really is lower, then perhaps that needs to move as well so that, again, we expand the field of therapeutic options.
Sure. And yeah, I think Dr. Coppock brought up a good point there is that hopefully it does continue to get easier, right? With the data that we have from RADAR, obviously with the new KDIGO guidelines and, recently now with sparsentan's full approval and that proteinuria language being removed, whereas now the medication is recommended just to slow the progression, of kidney disease without having that proteinuria barrier. So hopefully, that'll also help. So I know we're coming very close to time, and I wanted to just give the panelists, an opportunity if anyone had any closing thoughts or any final kind of comments, whether it be on IgA nephropathy or sparsentan, to certainly open up the floor to you all before we close here in a few minutes.
I'll go, I guess. I think sparsentan is a drug, in my experience, that patients feel more comfortable with because it has this kind of RAS backbone, and then the endothelin antagonist component is there as well, which is like not a new drug, as Dr. Udani had referenced. So, I mean, my approach with IgA nephropathy, especially when we're talking about targeting HIT4, the terminal pathway, is that sometimes it feels like any drug you throw at that pathway has benefit in the disease. And I don't know exactly what that means, but the data can feel so compelling for really like anything that we have, SGLT2 inhibitor, RAS blockade, endothelin receptor antagonist, et cetera. And so like when I approach a patient and when I talk to patients, it just feels like to not add an element, as long as they don't have adverse effects to that option, feels like I'm not offering them everything that I can to help modify their disease. With immunosuppression, I think you always have to exercise that extra element of caution, as Dr. Udani already mentioned. But with these pieces of non-immunosuppressive proteinuria management, I feel like, it just feels appropriate and important for our patients.
Yeah, that's a great summary. And I think that from the clinician standpoint, I think the other thing is just growing more comfortable with, multi-drug therapy for disease control. And the heart failure folks probably pioneered this, We're adopting it in diabetic kidney disease, the concept of GDMT. I think we have to expand that to IgA as well. We're saying, okay, it's not going to be a single drug, certainly not a single drug for everyone. It's not going to be a single drug to keep disease controlled over the lifespan of a patient with IgAN, and that, and again, also laying those expectations out and outlining that with patients, understanding that this disease comes and goes. There's foundational therapy to be in the background to protect your kidneys. But there may be add-on that we have to do for periods of time so that we can keep renal function preserved. Again, especially when we're talking about people in their third and fourth decade of life.
Thanks. Well, yeah, on behalf of Travere and Dr. Hendry, thank you obviously to ISGD for giving us this opportunity. And thank you, to our wonderful panelists, Dr. Udani and Dr. Coppock. So I will turn it over to Laurel to close us out.
Thank you. Well, thank you to all of the panelists for your insights, and thank you to everyone who tuned in today to attend. And I hope that you will follow ISGD on social media and subscribe to our newsletter to learn about upcoming other events that we have. And thank you again for joining us. And we hope this was interesting and useful to you.